Bismillahirrahmanirrahim. Assalamu alaikum. I am Bushra Saeed, student of optometry and orthoptics final year, and I am from Rashid Latif Institute of Allied Health Sciences. And I am participating in OcularDDtalks. So my topic of presentation is amblyopia. Firstly, we discuss about the contents of amblyopia. We discuss the introduction, classification, risk factor, etiology, clinical features, complication, investigation, and how to treat the amblyopia. Now I'm going to talk about the amblyopia. So what is amblyopia? Amblyopia is a Greek word, means blunt eye, also called lazy eye. And how we can define it? Amblyopia is unilateral or bilateral, decrease in best corrected vision caused by foam vision deprivation and abnormal binocular interaction, for which there is no identifiable pathology of the eye or visual pathway. Okay, moving on, next step is classification. The first one is stimulus deprivation amblyopia, in which lack of visual stimulus, it may be complete or partial. Complete where no light enter the eye. In partial, some passage of light into the eye. Strabismic amblyopia, which is the result of manifest strabismus. Third one is anisometropic amblyopia. Difference in refractive error of two eye. It is called anisometropic amblyopia. Meridional amblyopia, which is the result of uncorrected astigmatism. Ametropic amblyopia, which is the result of high degree of uncorrected refractive error. Last one is occlusion amblyopia. Occlusion amblyopia is the amblyopia to cover the non-amblyopic eye for couple of hours. It is also called reverse amblyopia. So, this is the picture of normal eye and astigmatic eye. In normal eye, light rays focus on the retina, but in astigmatic eye, light rays are not reflected properly. Risk factor. More prevalent in low birth weight and premature babies. More common in delayed milestones and central nervous system disorder. Parent with amblyopia, maternal smoking. Etiology. Amblyopia is proposed as the visual cortex area P1, where there are marked changes with loss of binocular driven cell and loss of neuron driven by the amblyopic eye. Changes are also found in area B2. Amblyopia may be unilateral and bilateral, and the cause may be any or a combination of the following factors: light deprivation, foam deprivation, abnormal binocular interaction. Light deprivation. There is no stimulus to the retina, for example, dense cataract and ptosis. Foam deprivation. The retina receives a defocused image as with refractive errors. Abnormal binocular interaction. Non-fusible images follow each fovea as with strabismus. Some other factors which causes amblyopia as follows: uncorrected astigmatism, anisometropia, and manifest strabismus. Clinical features. First one is visual acuity is reduced to 2 or more than 2 lines of Snellen test chart. Second is pinhole test show no improvement in vision. Third is crowding phenomena is present, that is vision is better when tested by single words than multiple letter chart. Fourth one is head tilting. Fifth is an eye that wanders inward or outward. Sixth is poor depth perception. Last one is squinting or shunting an eye. Complication. Blindness. Blindness is the only complication of amblyopia. If untreated, the patient may eventually lose vision in the affected eye. This visual loss is usually permanent. So this is the picture of amblyopic patient. Investigation. Refraction. First one is refraction. Refraction is the most important step in the investigation. We do refraction of anisometropia, high astigmatism, and bilateral high refractive error. Second one is case history. Case history is also most important step. Check the early onset unilateral constant strabismus with long duration. Check congenital ocular abnormalities such as cataract and ptosis. Third is visual acuity. Check the visual acuity by logMAR chart. Fourth is contrast sensitivity. Then we perform cover test. There may be ptosis that can be unilateral or bilateral. Then we perform visor scope to check the fixation may be eccentric or wandering. Also, we use the neutral density filter in investigation of amblyopia. In this, we tested visual acuity with this filter, and visual acuity is not reduced in amblyopic eye. Okay, let's talk about the treatment. Correct the refractive error and treat the amblyopia. Removal of obstruction to the VN, for example, removal of cataract and correction of ptosis. Occlusion of the normal eye to encourage the use of amblyopic eye is the most effective treatment. Starting level of occlusion is between 2 and 6 hours daily, coupled with near or distant activities. After that, time period should be increased according to the age, but an ideal goal is less than 400 hours of occlusion or 6 months of occlusion treatment. Late occlusion in the age group of 7 to 12 years has been shown significant improvement 53% and in 25% in those aged 13 to 17 years. So this is the occlusion therapy chart and this is the video of patching. Now we discuss the further other treatment, penalization, in which vision in the normal eye is made blurred with atropine as an alternate method. It is the best treatment of mild amblyopia. Computerized treatment, virtual reality based display system, Pleioptics, photorefractive keratectomy used for the treatment of anisometropic amblyopia, levodopa and carbidopa used to improve visual acuity, but it has some side effect. Cycloplegic stuff, that is cyclopine or atropine. That's it. I tried my best to deliver a little bit information about amblyopia. Thank you